Hello, hello, welcome everybody. We are so super excited to be gathered here today, both in person and online, as a community of learners, faculty, and students across medical and public health disciplines for the inaugural Anti-Racism in Medical Education Symposium, sponsored by the Macy Foundation, the Fund for Public Health New York City, and the Association of American Medical Colleges. My name is Tony Eyssallenne, and I work in partnership with Dr. Michelle Morse, the Deputy Commissioner for the Center of Health Equity and Community Wellness, who is also our inaugural Chief Medical Officer. And I also work in partnership with the wonderful agency staff, some of whom are here today, that keep the division and CMO office afloat and help bring this day to fruition. As an internist and as a pediatrician, native New Yorker, Queens, okay, and as the senior medical advisor in this new office, I am honored and also feel quite lucky to be among them on a daily basis and among you for the duration of the day together. I want to ground us today in a couple of stories. A 60-year-old black male with hepatitis C and hypertension comes to a clinic where I was teaching medical students in residence. He was not feeling well, he was a bit dizzy. We check a blood sugar, and it is through the roof. We send him to the emergency room with a letter with his diagnosis of new onset diabetes. When I review the documentation in the ER the next day, I see that he was diagnosed with uncontrolled diabetes with a risk factor of noncompliance. When I checked the admission note, he was again diagnosed with uncontrolled diabetes due to noncompliance. So instead of getting the counseling that he needed for a new diagnosis of diabetes, which he had, he received counseling for an uncontrolled diabetic not taking his mythical medications, even after his primary care doctor sent him with a letter that provided his new diagnosis. Dr. David Ansel is a prestigious anti-racism scholar, and I was able to attend one of his grand rounds in recent years. During his lecture, he put a picture of a 15-year-old black teenager from Chicago on the screen and asked the prestigious academic audience, "What do you think he will die of?" And in unison, this prestigious academic audience said gun violence. In unison. Now, there may be some of you here who may be asking, why am I making a big deal out of this? Isn't it gun violence? And I will answer you in the words of Dr. Ansel, who said, and I'm paraphrasing, "As a student of epidemiology, the #1 killer at this moment in time is cardiovascular disease, and so he will likely die of a heart attack." But he put the picture of a black teenager from Chicago on the screen, and the audience immediately went to gun violence as an inevitability, despite the fact that we are educated on epidemiology in our medical school curriculums. Dr. Kamara Jones's definition of racism is the strongest in my view, as she defines it not only as a social system, but as a social system with multiple dimensions. And individual racism is internalized or interpersonal, and systemic racism is institutional or structural. It is a system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and it saps the strength of the whole society through the waste of human resources. So when we are talking about anti-racism, we are not simply talking about not being racist. We are talking about an active process that focuses on dismantling the power structures and systems that create and perpetuate inequities across racial demographics. We are here today because racism, as I have illustrated in my stories, is embedded in medicine. It is so embedded that our colleagues have designed clinical guidelines with race adjustments based on the same philosophy that had the audacity to change the diagnosis of a primary care patient in crisis, well known to the practice, not once, but twice, in 2 different departments, and assume the cause of mortality in a child based on phenotype and location. While the art of practicing medicine may allow for versatility in one way that a provider takes care or approaches a condition compared to another, whether acute or chronic, there are fundamentals that we as a profession need to agree on in order not to cause harm. We need to be unified in our understanding of racism and anti-racism. We need to remind ourselves, when necessary, and our colleagues and those they teach, that race is a social construct, it is not a proxy for genetics or ancestry, and the demand for rigor to even consider de-implementation of race adjustment was never even debated when it was implemented in the first place. And so on the heels of the New York City Board of Health declaration that racism is a public health crisis, the New York City Department of Health and Mental Hygiene's inaugural Chief Medical Officer, Dr. Michelle Morse, in partnership with health systems across the city, convened the first coalition to end racism in clinical algorithms, also known as CIRCA. The objective of CIRCA is to promote a healthier and more just healthcare landscape in New York City by convening stakeholders across public health, health systems, clinical research, health informatics, and social sciences. Each member institution is required to submit 3 deliverables: a work plan that's describing initiatives to end race adjustment in their algorithm of focus, an evaluation plan describing how to measure impact of ending race adjustment on patient outcomes, and a patient engagement plan to engage patients whose care was negatively impacted. We have convened 10 health systems across the city who have committed to a 2-year time frame to eliminate race adjustment in 3 clinical algorithms: EGFR, estimated glomerular filtration rate, PFT, pulmonary function test, and VBAC, vaginal birth after C-section. We are in our 2nd year where the focus has been on designing patient engagement plans and have resulted in a collaboration with the National Kidney Foundation in their campaign to educate Black New Yorkers about the underestimation of their kidney health as a result of the inappropriate race adjustment, a video focused on educating birthing humans about their opportunities to consider a trial of labor for a vaginal birth after C-section, instead of being risk stratified for a C-section based on race, which has contributed to poor outcomes in Black and Latin people. And most recently, the long awaited statement from the American Thoracic Society, finally denouncing race adjustment in pulmonary function tests that have underestimated pulmonary disease in Black and Asian people. As part of this work, we recognize the value and the power of including our colleagues in medical education, as well as our learners in this process, because this is where we can actually change it. There is groundbreaking work being done here in New York, and we need the world to know about it. And so, this is your day. This is your day to share your courageous and disruptive ideas regarding eliminating race adjustment in clinical algorithms in medical education and get feedback. Ask for help and create collaborations, whether you are a dean or a student, in a safe space, so we can collectively move the needle in anti-racism in medical education toward a real commitment to not only health equity, but to health justice.